almost 60% of the patients who had died were actually suitable donors. And out of them, we only managed to approach 50% of the patients.
Especially to those organs which is quite vital, like example of a heart and liver. So this is considered as a definitive treatment as well.
Dr. Hasdy bin Harun is the Deputy Director of Malaysia's National Transplant Resource Centre, or NTRC. As a leading voice in organ donation advocacy, he worked tirelessly to raise awareness about the gift of life and the hope it brings to patients awaiting transplants. He is also committed to educating the public and dispelling common myths and misconceptions about organ donation. Dr. Premala Naidu is a consultant intensivist at Subang Jaya Medical Centre. She has extensive experience caring for critically ill patients with a deep commitment to patient-centred care. Beyond her role as an intensivist, she has also been actively involved in organ procurement and transplantation for over 15 years, supporting patients at every stage of their transplant journey. According to My Sejahtera, over 400,000 Malaysians have registered as organ donors, but if you look at the waiting list, right, more than 10,000 patients are still on the waiting list right now, pending maybe an organ for kidney or liver, for example. And allegedly, some will wait up to 10, maybe even up to 15 years as well. And what we're trying to find out today is why is registration isn't translating into viable transplants. So I guess I want to start off with the conversation on transplants first, right? I don't think it's something that we see very vividly compared to other diseases like, heart attacks and heart failures, right? But let's maybe start with that point of why is transplant necessary? Is it something that's critical? Is this something that's very, very urgent?
Transplant is definitely something that is going to change the patient's life. If they have been, for example, let's take a kidney patient.
Yeah.
For example, and they've been on dialysis. So what does that mean? That means they have to go in for dialysis at least 3 times a week, right? And they spend almost maybe 3-4 hours there. But it also, we have to take into account, they have to drive themselves or get somebody to drive them there. And then after the dialysis, there is a downtime as well. So, it takes a lot of time and energy. And on top of that, the cost of the dialysis, if that person is the sole bread earner in a family, so imagine what the family is going through, So having a transplant would actually improve the patient's quality of life. Right. They can go back to work, they can, spend time with families without worrying about having to get to a dialysis center. They can travel, so that's one of the reasons why it is very necessary. And sometimes transplants can be life-saving. For example, in a patient with heart failure, end-stage heart disease, and they are on the LVAD machine, which of course has a lifespan as well. But if they did get a transplant, then their life is so much better.
Right. I want to ask you, Dr. Hasdy, because you at NTRC, you guys coordinate the organ donations and then the transplants as well. From both your practices, actually, right? When we say life-saving, when we say improving quality of life, are we adding a substantial number of years to a patient's life when they successfully get a transplant, typically?
When patient receive a new organ to replace their damaged organ, we can prolong their life. I mean, for solid organ transplantation, regardless, is more to life-saving in a way. Although we can say that maybe renal would have other modalities to do their treatment, but we are all agree in the medical fraternity that transplant is a gold standard for the treatment of choice for solid organ and stage of organ failure, especially to those organs which is quite vital for the example of a heart and liver. So this is considered as a definitive treatment as well. So without transplant, this patient will not survive. That's why when you saw the list also, you can see 10,000 patients waiting. Primarily is a renal patient, but very little numbers of heart and lung and liver. And why? Because this patient may succumb to death while waiting for organ.
Right, because kidney, you got dialysis.
Yes, right. So that is what's happening also. In reality is transplant will prolong this patient chances for life. And with a good advanced medical and so on, then we can do now that this patient can live as a normal healthy person actually. Yeah.
In fact, in last year, we had our MST 50th year celebration, and we did invite some of the organ recipients for the function. And I met an old uncle who was in his close to 90s, and he told me that he had received his kidney about 38 years ago.
Oh,
Yes,
yeah,
and
yeah.
yes, and he was still up and going, and he was so proud that
Wow.
he had,
That's interesting. 38 years.
yes.
You would hear stories of maybe extending a lifespan of an additional 10, 15 years, but 38 years is actually
Yeah.
quite a remarkable
Yes.
number.
Remarkable, yes.
Right. So from both your practices, right? So we've got 400,000 donors, registered donors, right? 10,000 are still waiting, and of course there's the daily death rates and things like that. The numbers doesn't seem to add up. We've got a lot of donors allegedly. Is that not enough?
Yes, definitely. It's what we are looking at is the number of pledges,
Yep.
right? But that doesn't translate into actual donation.
Okay.
What it reflects is the awareness,
Yep.
the level of awareness amongst the public.
Yeah.
Yeah, that's all it is.
Right. So it doesn't necessarily mean that's viable organs on hand for
No, that
transplants to
does
take
not
place,
at all.
right?
Yeah.
So from your side, Dr. Hasdy, do you feel that when it comes to the list, then it's a very tough thing to manage because these are people waiting years on end for a heart, a liver, kidney, lungs for that matter. Tell me a bit more about what you do then at NTRC, right? When are you able to then coordinate that liver or that organ to the patient that needs the organ?
In NTRC, we focus mainly to coordinate disease organ donation and transplant. So while we're aware that the numbers of patients in the waiting list is quite significant, like Dr. Prem mentioned also, the 400,000 of the donor register does not necessarily can be translated to the actual donor. So this is the reality that we are facing also, because when we talk about disease donation, of course, the opportunity will come when we had a potential deceased donor in the hospital. So this is where the NTRC play a crucial role to ensure that this potential donor in the hospital can be identified to convert to become actual donor. In NTRC and even for Ministry of Health, we implement our donation team in the whole hospital, in the public hospital particularly, and we have about state hospital and then of course a major hospital like in Klang Valley. So this is what we call unit perolehan organ hospital, or some other hospital we call it top team hospital, tissue organ procurement team hospital. So by implementing this team in the hospital is necessary, because when the patient or with the suitability or the potential of the deceased donor were identified, were detected, this is where the process will be going on from the moment we detected to convert to become actual donor.
Right.
So this process is quite a lot actually.
Yeah.
I mean, you have not just to identify, you need to evaluate, you need to assess, you need to, for brain dead patient, you have to certify the death first and so on. So, and then finally, the most important critical point is actually you have to ask, you have to approach, you have to meet, you have to counsel the donor family, the patient family, whether they wanted to give a donation or not. So we need to do this until that we can get the consent, and then after that we also need to mobilize our procurement team from the mainly from KL to all the donor hospital to do this procurement, and then after that also we need to make sure the safety of the organ, to picking the organ, to be brought back to the transplant center. And concurrently, while we have a donor, we also need to already stand by at the recipient side to actually select the recipient, to match the recipient. That is another challenge also. Yeah. So it's not just have a donor, you have to get the recipient done, and then you have to match pretty good, and then the transplant can be done. Yeah.
So that's a very complex
Yes.
series of coordination, actually, if you think
Yes,
about it.
It's very complex, and in addition to that, if the procurement is done in a far off place, like for example in Kelantan, then the organs have to be flown in to the Klang Valley, to the major hospitals to be transplanted. And also the recipients may come from Sabah or Sarawak, so they have to be also transported to the hospital.
I suppose from both your work, it sounds like we clearly don't have enough pledges, maybe, number one, but we also perhaps don't have enough conversions of pledges who then literally become deceased organ donors later on. Why do you think that's the case from your experience so far?
Well, I think there are gaps at various levels, okay? And what is the most important, the beginning of this process is identifying the donor.
Right.
So donor identification is very, very important.
Yeah.
And we definitely lack in donor identification, even though we have the UPO teams, the top teams in the hospitals, but empowering them to go and look for the donors, that's a hurdle that we still are trying to overcome.
Is that typically a role done by the hospital, or is that something necessary for family members to declare?
Well, yes, that's exactly why we tell the family members to have a discussion, with their especially if they have pledged.
Yeah.
So we tell them to go back and have a conversation with the family members and express their willingness. You said, there are only about like 400,000 or slightly more number of pledges, and not all of them translate into donors, you see. So a lot of the times our donors are unpledged, and for the very first time the families are hearing about organ donation. So that is also a situation that occurs, especially in the ICU. In fact, the approach for organ donation is one of the most sacred conversations that we have in the intensive care unit. Timing is very, very important when we approach them. And a lot of the times family members are hearing it for the first time, or they are so into the grieving process that, they actually suddenly realize, oh yes, that is something that the patient had wanted to do. Even though they hadn't pledged, So we've had encounters like that as well.
So especially from your side, because you coordinate that conversations, right? Is family decision making, or for lack of better words, family veto a major hurdle that's stopping people who are pledges to actually donate their organs sometimes?
Like Dr. Prem said, it can go both ways actually. When you get the consent, it's either the family also can initiate. They want to donate. And the second one, we have to ask them. Dr. Prem also mentioned this is very, very different situation because they are grieving actually. So some of these family members may not think about donation at that point of time. This is that we have to understand. So that is why it's very important for our coordinator, and even from the ICU and then UPO at the top team, the coordinator, they need to have very much good rapport, good explanation, good counseling to the family member to ask about donation. Most of the time, family will say no also. And in fact, in our data, majority family will say no. Our refusal rate is quite high actually. About 80 to 90% actually family would say no. But having said that, we need to also understand why they say no. For our coordinator, we are trained to understand the dilemma or the challenge or the issue that raised by the family. Why they say no? So this is where the conversation become very, very critical. And we manage to change that perception at the time of conversation as well. When they say no, why? Maybe they were worried about funeral delay, maybe they worried about mutilation, maybe they worried about religion. So the role of conversation is very important at the time. So the coordinator need to highlight, to address that issue, need to explain, and you will not believe that some of this perception, then the family would say yes after that, because they would understand more and better why actually donation is actually allowed in the religious perspective and so on. So I think in any system that we can opt in the country, whether we are opting in, opting out. Even you look at the other country like Spain or even in our country, in the end of the day, the counselling session or the conversation between family and the coordinator is very important.
Yep.
How we convey the message, how we talk about donation, how we explain to the family, and so on.
Yeah.
So there are hurdles, but the hurdles can be changed, can be improved if we know how to do it very well.
Yeah.
Yeah.
And I think with your leadership happening at NTRC, that's clearly happening very well. You mentioned a really interesting point, and I think I want to double down on that for a little bit, because I mentioned countries like Spain, Singapore. You can even compare to maybe Saudi Arabia, Turkey for that matter, right? Clearly, there's a few key components to see how a organ pledging to organ donor to transplant process works out well. I can already imagine there is that population part whereby population awareness needs to be done correctly. There's perhaps an infrastructure part with the coordination that you do, and maybe even capacity at the individual hospitals as well, right? If we compare ourselves just at the surface level to all of these other countries, where do you both think we are faltering at the moment?
So I think the question here is, why is it that in a population of about 34 million, we only have about 400,000 pledges?
Yeah.
So it boils down to awareness, public awareness, okay? So we have to look back at how are we doing our campaigns now? Well, we do it in the hospitals. We have kiosks in the hospitals. Now, let's look at our clientele. They are patients. They are people who are ill, who are coming in. They are rushing to see doctors. They're rushing off to get their medications at the pharmacy, you know, and the family members are busy looking for a parking space. So, you know, I think pledging is the last thing in their mind. And I don't think this is the target clientele, you know. We should be doing awareness programs in a bigger scale. So it has that burden right now is on the hospital staff who are already overworked. You know, so it's like breaking the camel's back, you know. It's just too much. So it has to be taken out of from the healthcare workers' shoulders and put it out there. So we need advertisements on TV, you know, repeated reels on TVs, on social media, huge advertisements on billboards, and probably even at a ministerial level or even in the government should take some responsibility in creating awareness and talking about it, you know, opening conversations. So that's the only way I think we can increase the level of awareness.
Yeah. So it's definitely a wider approach rather than a hospital-focused approach. And I think you're absolutely right, because I believe as you have those conversations coordinating with family members and whatnot, if you're in a hospital, the last thing you're thinking about is, you know, pledging to be an organ donor.
Yes. Right? I agree with Dr. Premala. For the hospital, they only need to educate the hospital staff.
Correct.
Yes.
Not the public.
Correct.
Yeah. So for what Dr. Prem has mentioned, because people came to the hospital also with different reasons.
Correct.
They don't want to become a donor.
Yeah.
They want to tackle their illness, to treat their illness and so on.
Yeah, and nobody likes to stay in the hospital.
So basically, for the hospital, what we do, we need to educate the healthcare staff. In fact, many years ago, so we launched what we call KKM Jom Ikrar, Ministry of Health Jom Ikrar, because that program is actually to show example to the public that the Ministry of Health also on board with the program to register from the top management up to the hospital director to the lower staff and so on. So this is to lead the example to the public. And then like Dr. Prem also said, the wider concept of campaign need to be sustained. In fact, we had done a few campaign before. And we, in fact, strategize a few public awareness strategies, among others that we collaborate with some institution like a religion institution, like for example, JAKIM and so on, to come up with awareness among the Muslims, to focus to the certain group and specific group. And then, of course, we have ambassador program that we appoint a few influential people to talk about donation and so on and so forth. I think there's a lot of organ donation awareness strategies that we come up. But maybe what we lack is actually the sustainability of this program. We have that for many years back, and now we are stopping this program. Then now we want to restart again. So it's become quite difficult and challenge. So, and the other thing about awareness is actually we need to realize that it is a responsibility of everyone. It's not just Ministry of Health. Then I don't think Ministry of Health can do this alone. They need a good collaboration with other non-government organization, some professional societies, professional body, private hospital, university, private college. We are all in the whole society need to do this together. You look at the other country like in Thailand, in China, the public awareness were carried by people who is non-government organization like Red Cross Society and so on. Because the public will trust people, the independent, the non-political or government related. So this is where the public cause are more strengthened or more strong. So this is what I can see.
It sounds like to me from just the conversations, right? It's not an infrastructure issue at this stage, right? It's not perhaps a very big capacity issue in that sense, but rather we still are at that population awareness and willingness and education.
No, actually, we do lack capacity as well. Okay, because look at the number of surgeons that we have who can actually procure organs and transplant the organs. There are not many that we have, and we have to train more people. We probably need a hospital dedicated to transplant. I guess that is in the long run, but at the moment we should have more hospitals doing transplants. Including the private hospitals. So we do have the university hospital like University Malaya and UITM doing transplants, especially kidney transplants. And other than that, it's just the government hospitals, HKL, Selayang, Sungai Buloh. So there are very few hospitals which are doing it. You can count the number of surgeons.
Right.
So we still need to fill that capacity. Yes. Because when the demand increases, everything has to happen in a tandem, demand increase, we have an increased demand. We have a high demand, but we do not have the supply. And as the supply increases, we should also have the capacity to cater to that.
Okay.
So everything has to happen simultaneously.
So they have to be concurrent, in other words, right?
Yes.
So we ideally need more awareness, that whole community, kita jaga kita kind of mentality, right? Of being part of this society together, increase the number of pledges and hopefully increase the number of actual donations and donors for that matter. And that has to be in tandem, as you rightfully pointed out, with the expertise to execute those transplants, those harvesting of sorts as well. I think before we wrap up this segment, I do want to just touch on one key thing. We hear a lot of deceased organ donors and donations so far, right? Is that the only means of organ donation and transplants in Malaysia?
No, we do have living organ donation where family members, first degree family members, or sometimes even second degree are encouraged to actually donate to their loved ones. Other than that, these are the two, disease and living.
I would assume the reason why we emphasize a lot on deceased organ donation is because it's in a way a resource that's available for the betterment of society, right? But
so it's not just because of that. It's also zero risk to the donor.
Correct.
With living donation, there are a lot of things that can, the donor is put at risk. The donor is put under anesthesia with the risk of, undergoing a surgery to take out the organ and then to be transplanted. But this also, in what we have noticed in recent years in many countries, there have been organs that have been, sold. And so for us to control that, it's a bit of a problem. So we do not encourage unrelated unless they are spouse.
Right. No, because you see, you got 10,000 people on the waiting list, right?
Yes.
And so I would have assumed that surely they would have asked their loved ones for maybe a living organ donation first.
Well, yes, living transplant is another option, but not all organ can be transplanted by means of living. It's only one kidney and of course some liver, portion of liver, and the other of organ or tissues still need deceased donation to do. So I would like to re-emphasize what Dr. Prem said about living transplant. Well, in our country, we still allow living transplant, particularly the related transplantation of kidney and liver. And for the beyond that, after it's more than defined as a related third degree family, foreigner and so on, we will categorize as unrelated transplant. So living transplant in our policy was only supplementary to cadaveric transplant. Primarily, we still have to focus for deceased donation and transplant.
Yeah.
If there are no other ways of course, like you said, the demand is high, we still allow living transplant. In fact, we still can do unrelated, but it has to go by ethicals evaluation. So the concern is the ethical reason mainly. And then of course, bioethics principle that we had. There should be no new normal subject, human should undergo surgery by medical perspective. But there are certain benefit and between risks that we need to weigh in. That's why we have to allow also sometimes. So if we didn't promote or we didn't empower cadaveric transplant, we have to rely or to depend on the living. And depending on the living transplant will quite complex and delicate actually, because like Dr. Prem also mentioned just now, it can open to commercialization, it can open to human trafficking, it can open to many medical legal uncertainty. So this is where that regulation is needed and policy is needed, law is needed to make sure whatever type of transplant that we pursue and we have to go is still safely performed in the means of regulation and policy.
Yeah, so I think definitely in medicine, we always say first do no harm to patients, right?
Yes.
Right. So I think exactly that. So I think clearly from what we've learned so far is transplants are clearly a life-changing procedure, and unfortunately at the moment there isn't enough sort of supply to facilitate organ transplants and organ donations by extension. We do not have enough pledges. We do not have enough donors for that matter. And registration itself, like you rightfully pointed out, does not mean an automatic donation. And there's still a lot of things that we need to do to really increase that awareness.
I just want to talk a bit on the disease donation.
Yep.
Just now that Dr. Prem also has answered it. But let's look at the broad perspective. In Malaysia, there are about 6,000 to 7,000 people who died from road traffic accident in a year annually, and every year if you refer to JPJ data, this is happening in our country, and in fact we are among the highest country with road traffic accident. We don't need all these 6,000, 7,000 to become a donor, but a few only from this patient may suitable to become a donor. So where is the problem that we cannot actually detect or identify this patient to become a deceased donation? This is something that we need to address also. Yeah.
So, we do definitely need that population awareness for sure. And all of these things that are happening, whether it's an MVA or a disease-based passing on of a patient, for example, it itself has the potential to save a lot of other lives as well.
Oh, yes.
Right?
Like a few years back in my previous hospital, I actually had done a study on the number of deaths in the ICU.
Yeah.
And we looked at all the deaths for that year in 2015, and we realized that almost 60% of the deaths, the patients who had died, were actually suitable donors. 60%, you know. And we looked at those 60%, and out of them, we only managed to approach 50% of the patients, of the suitable donors. So that number was about 175. Why we did not manage to approach all of them, there were many reasons. Sometimes families were not there, or the doctor who had certified death did not think about approaching, so all those factors were there. But we managed to approach about 175 family members for donation. And out of that 175, only 21 consented for donation.
Wow. Right.
So that's the level of awareness
Right.
and willingness
Yep.
that we have.
It's funny that you say that because I feel like as part of this whole segment that we've been chatting on so far, it clearly is not just awareness on the population side, but also even in the medical fraternity as well, to alert fellow colleagues about a potential organ donation here as well. So I think we've really hit the point home, right? Which is the fact that transplants are super duper important. It saves lives, it extends life. However, because it does involve the need for an organ donation, we are in severe shortage of that at the moment, and hence the waiting list is the way it is. And we've got a couple of things to work in tandem to improve that facility, right? So patient awareness, broad-based marketing, for example, as well as the clinical capacity to execute those donations and transplants. Enjoyed this episode? Like and follow us for more conversations like this. If you have a topic you want us to cover next, drop it in the comments. We'd love to hear from you. So I want to talk a bit more about people who are not pledgers yet. And I think ultimately how infrastructure should work together, right? So maybe I'll start with the pledging first, right? What happens if somebody did not pledge and they pass on? I think you've hinted earlier on that potentially they could still be a donor, but walk me through that process a little bit.
Okay, first of all, we need to understand what is our legal says about consent. So in Human Tissue Act 1974, it's clearly that mentioned that the consent is we are practicing what we call as opting in, right? Opting in, and then the consent taking should be from the next of kin, from the next of kin, whether the deceased or the patient has pledged or give intention to donate while he was alive, with the witness by the family members, or the next of kin would give the permission on behalf of the deceased. So in our data, when we have about nowadays we have about I think 1,000 plus of actual deceased donor, and only less than 20 to 30% was actually a donor register. The rest was not actually a donor register. So with the soft opting in law that we have, we still able to approach all patients regardless of their donor register status. And people may ask why you need to register then, but the registration actually to make sure that to facilitate the consent much better. So the family might know your wishes, your will, and so on. They would easily to give consent. In fact, sometimes family may refuse because they're not sure what you want. Unless if the family are very close with you, they know how is your perception or opinion about donation and so on, they can give consent. So in this case, if you are not a register, the registration is not mandatory, in fact, to give consent. If you are not registered, but in your life you have ever said to your mother that if I die, I give my organ to anyway, with that situation also, the family will remember what you want and they will still give you consent for you.
Right.
So that's how it works.
Yep.
So even like in my family, my mother is she's around almost 80 years old. She would not want to go through the registration, but she would say that if anything happened to me, if my organ or my tissue can still be used, just donate. So this is also, in a way, you can give signal or you can tell your family that you want to donate. I think most importantly is for all of us, whether we register or not register, to discuss with your family members what you want after you die, and then the family can carry on these wishes when times come. Yeah.
So what I'm hearing is that sometimes the uncomfortable conversation of death needs to happen in the family, right? And I know for a lot of families that might be a very taboo thing to talk sometimes, right? Hush, if you will. But as long as you give a sign of intent, sometimes that is all that's necessary. But registration does help, I would assume, because it flags to the medical professionals that, hey, this is somebody who has registered to pledge. We should have a chat with the family, right?
Yes. But irrespective of that status, once the patient is identified as a suitable donor, then that conversation needs to be initiated with the family, irrespective of the pledging status. And the timing of that conversation is very important, because it is important for the family to have accepted the death, But the fabric of our society, our families are not just the next of kin. It's a bit more complicated. We have hierarchies, we have grandparents and uncles, like elder uncles and aunties who sometimes make the decisions. So even though the next of kin, like for example, the wife of the patient decides to say, yes, I want to donate, but if the rest of the family members veto it, then it cannot happen.
Oh, that's interesting.
Yes. So it is very complex.
Right.
It's not an easy thing to deal with.
Now, here's a funny little, I suppose, cheeky even little thing, right? Can someone choose selectively what they want to donate and what they don't want to donate? Maybe the idea of a cornea being taken out is just so vividly scary that, no, just take anything inside, but not my face, right? Is that viable?
Actually, last time we do option. When we introduced the registration many years ago, we start from the manual registration, and then website registration, and now MySejahtera. And from the beginning that we started do this registration, we give option what organs and tissues that you would like to donate after you die. Then after we introduced MySejahtera, we somehow didn't give the option anymore to the public or to the register, because for disease organ donation, the suitability, what type of organ and tissue usually has a few factors that can determine that. One, of course, the consent, and then number two is the suitability from the medical perspective itself. Maybe you want to donate only kidney, but it turns out your kidney was not well or was not suitable at the time of death. So if you have already decided only single organ that you want to donate, you will not have chance to give other organ based on that. So that's why when we opt out using the option, it relies on the family members, what kind of organ or tissue they would want to give, and also relies on the medical side. We would advise also the family which organ and which tissue at this point of time which is suitable for transplant or for donation. So, technically also, if you register, you may think that you don't want to donate your eye, for example. And then, but there is no option to select. It encourage you to talk to your family members.
Right.
So you have to talk to them. Okay, I already registered today, but please be reminded that if the times come, only give my internal organ, something like that. So indirectly you initiate some discussion with your family, and then you give some advanced directive that they only want an internal organ and something like that.
Right. So the chat with the family is more important, and you sort of in that sense can selectively choose what you're willing, what not you're willing to do, right? What are some of the biggest blockers? You already mentioned hierarchy vetoing in, right? But are there certain beliefs or misunderstanding that we could take the chance to educate the public right now as well?
Yes, actually, most of our families that we have approached or we have encountered, some of them even never heard about organ donation sometimes, especially at the rural areas. That's why we don't have many donors at the states which has less public awareness. People who is from very rural areas or district and so on. So some of the reason first is actually they were concerned about things that may related to the cultural belief or religion. For example, delaying the funeral, and then of course mutilation, and then of course afraid of the mutilation. They may thinking that donation or procurement itself is just like a autopsy or a post-mortem procedure, which actually is not right or is not true. So they didn't know that. And then another thing is, if you take the organ and the body will be not complete. Some of the cultural or religious belief that the body need to be complete after after death to the hereafter. So this is also another concern. And then sometimes they also doesn't want this process to become, they may seem that this process may cause more suffering to their patients, because some of these patients may stay in the ICU for sometimes, for 1 week, and then suddenly they want to go another surgery. So this also can give some emotional burden to the family members to decide. So this is among of the reason they would highlight it. And then of course see some religion obstacle. So in general, all religion in Malaysia allow organ donation. In fact, in Muslim or in Islam also, it is allowable. We have a fatwa that has actually stated that permissible, dibolehkan ataupun diharuskan. However, sometimes religious understanding could be differ from one to another also. Then we also have a federal fatwa, then we have a state fatwa. That's about fatwa. Then we also have some section that may say organ donation is not allowed. Some other preacher or Muslim preacher that may say this is not allowed. So this is difficult because when we want to try to correct their belief, is they will only follow certain order or certain understanding. So this is another factor that we can conclude.
So clearly education's a key thing here.
Yes. And you know, with regards to mutilation, people need to be aware and understand that the organ procurement process, it's a surgery that is done like any other surgery. It's very, done in a very respectful manner. Anesthesia is given to the patient, and the organs are taken out with all the due respect. It's not mutilation. It's definitely not mutilation. And after the surgery is over, the skin closure is done so neatly, and it is possible to have an open casket funeral as well. So that is a very important thing that the public should know.
Right. Let me just read to both of you a statement that I've gotten from family and friends, right? And so when talking about the idea of a viable organ donation that can take place with a loved one, this is the sentiment that they gave. They said, if I consent to this, it feels like I'm giving up on my loved ones. What do you both think?
Okay, it's not about giving up, because the loved one has passed on. Okay, so what remains there is just a body with viable organs. And this is something that the patient is able to do beyond death. Organ donation is the patient is able to give the gift of life even after he has passed on. So I think that is the take-home message for everyone.
Yeah, I think it's true. I mean, when we talk about organ donation, the most important thing that we need to understand why we do this. The objective weight more than what is the concern that we have. For example, if we think that this would upset, but we know that when we want to donate, we help other people. That's why when we do the conversation, our coordinator, our doctors who's involved with the conversation, we really highlighted the kindness of this action. When you donate, you can save up to 8 people. When you donate, this child can be saved. When you give 1 kidney, when you give a liver, 1 life or 2 life can be living as normal as it is. So this is all outweigh the concern. We may concern about a lot of things, or we may upset it. But people wanted to listen the outcome or the positive. That's why we are telling people organ donation is touristic. This is beyond anything that we can gain actually, except saving people.
Yeah, it's a very noble gesture. You know?
So in a way, it's also allowing your loved one to have that final dignity of helping other people before they pass on as well.
Yes, yes. Organ donation is a human right.
Right. From your practice, Dr. Prem, are there instances whereby this sort of preferences either facilitated an organ donation or maybe even hindered an organ donation for your practice?
Yes, there have been incidences where family members have a conditional consent, meaning they would consent to donate provided the organ goes to someone they know or or to their loved ones. In Malaysia, actually, we do not encourage that. We do
Okay.
not practice that because we already have a waiting list. So, this organ donation is it's a noble gesture. So it should not be conditional. It should be, there should be a willingness to donate without any
Prejudice of sorts.
yes, yeah, without prejudice.
Right.
Yeah, so when we try to explain to them, sometimes they agree, but there are times when they do not
I see.
agree to donate. Yeah,
see.
that has happened.
In that sense, that's really that whole ideation that if you are choosing to donate, it is really for the betterment of people who are urgently needing those organs, right? And you cannot sort of like, I'm going to keep this for my safety nest and one day in the future.
Yes, because it turns out to be transactional then, like a buying and selling kind of organ trafficking kind of situation. It's ethically, it's not right.
Right.
Yeah.
Right. So I think the ethical side of things, that's probably where that line is drawn. But certainly, if this encourages you to have the conversation with your family members on what you're comfortable with, it's definitely still viable in that sense, right? So I think for those who have not registered, it's a very straightforward process. But most importantly, from our conversation in this chat so far, you've got to have that conversation with your family members, your next of kin.
Yeah.
So I want to end on a hopeful, optimistic note. We talk about some of the challenges we have with organ donations here in Malaysia. I want to talk about what we can learn from other countries. And I believe you've already alluded a few things in terms of population awareness, right? But let's talk about other countries for a moment. We've roughly brought up Spain, Singapore, for example, with much higher donor rates in respect to their population size. What do you think they're doing differently that we perhaps could learn?
Well, Spain is one of the highest country. They have a very good organ donation number, disease donation. And everyone will always say that because of Spain practice opting out, that's very, what we can see, distinct differences between Spain and Malaysia. But I think it's not just about the opting out system. Spain has very good transplant system as a whole, right? Not just about the consent or legal perspective, but the whole transplant system in Spain are very organized. They have a very good structure of TPM or transplant procurement management, and they have a very good governance of transplant. They have also quite adequate support and, of course, government involvement in the transplant that encourage and nurture transplant in the country.
Yeah.
From donation side, procurement side, until transplantation side. And the integration between the public hospital, university hospital, private hospital also plays an important role to support the activity. So when this has been strengthened and the facility, the resources, and then there comes the policy, the legal aspect, and then of course the healthcare professionals are quite pro towards transplant. So that's why they can actually increase their commitment or their numbers donation to transplantation, because we need to understand, in order for transplant to thrive also, the ecosystem between donation and transplant need to be balanced, need to be run like Dr. Prem mentioned before, so concurrently in tandem. Then because it's no point to have more donors also when we cannot do more transplant, and also no point or vice versa. Or so the ecosystem, the cycle of transplant, actually in the end of the day, when this cycle donation is high, patient can receive transplant, then public will trust the system, then more people will donate, and so on and so forth. So it's a cycle actually. So Spain has this actually. Their citizens, their population are very trust of the healthcare. When they want to do transplant, it's not necessarily at the Kuala Lumpur. People from Sabah also can do transplant. People from Kelantan also can do transplant. So this is something that need to be learned from their model or their system.
You mentioned an opt-out model. Does that mean that by birth everyone is an organ pledger in that sense?
Okay, opt-out system is actually defined as what we call as presumed consent.
Okay.
Which meaning that people were presumed to be an organ donor when they died. Okay, they don't need a registration. But in Spain, I think they transitioned to the opt-out system maybe more than 20 years ago. I'm not sure the year of transition. But for any country to transition from opting in to opting out, first of all, they need to ensure that the awareness is good. You need, I think, around more than 50% of the population to be aware or to be very well educated of transplant on donation. Then you can change the system.
Yeah.
If not, you got a very negative
You get backlash instead.
Backlash and so on. That's number one. And number two, although Spain practiced opting out, they actually didn't practice the typical opting out that we may assume. So what they practice is what they call is a soft opting out. So despite opting out, they will still have to conduct family approach, family interview, counseling, and would ask consent as normal as the way that we take about opting in. So the differences is simple.
Okay.
If we are in opting in, we would ask the family members, do you know whether this deceased has mentioned to donate their organ? But in Spain, they would ask, you know that this deceased has mentioned no, don't want organ donation. So it's just different dialogue.
Yeah. No, but the paradigm shifts a lot, right? The train of thought shifts a lot. Everyone is presumably already in that mindset.
Yes.
But you brought up a very good point, which is the fact that if the education baseline is not there, it won't work. Because I had this autocratic mindset whereby, yes, let's make everybody into an opt-out system, right? And let's lock everybody in. And I just realized, for example, the recent SOCSO implementation, the backlash that came from it as well. So it's interesting that you mentioned that, because the population has to be ready first. And that's where we mentioned about the education, the mass marketing and all that. You rightfully pointed out then also the fact that it cannot just be one thing in silo. It has to be an ecosystem, right? And I want to double down that with you a little bit, Dr. Prem. When we talk about ecosystems, right, the coordination between the hospitals, the university levels and things like that, when we compare ourselves with these countries, right, we know about population awareness already, but in terms of the ecosystem itself, where do you think we're falling short?
I think the registries.
Okay.
We have multiple registries. For example, the Ministry of Health has one registry, waiting list, and then the university has a different waiting list, and then private hospitals that are doing transplants have a different waiting list. So I feel for us to have a very concrete system, we have to merge. Merge our resources, merge our surgeons should go on call, maybe get all the lists together and, prioritize accordingly. So I'm not sure how we can do this, because our health system is such, we have the private health and then the universities and then the public health, which is all working,
little bubble,
yes, as you put it. So I think that is one of the reasons. And also the fact that, okay, let's say, for example, we have a deceased donor. We've presented the organs to the Ministry of Health, and they do not have a suitable recipient. Then what do we do with this suitable organ? Can we then open it to the universities? Can we then open it to the private sector? Or can we then even open it to the neighboring country? Why waste that organ? You see? So all of these things need to be addressed.
Because organs can't be stored in that sense, right?
Yes,
right?
Yeah. So one of the reasons why Spain is doing so well is they have very advanced technologies. Now, they don't only rely on brain death donors. They also have DCDs, which is donation after circulatory death. And in those patients, they actually apply advanced technology to preserve the organs and revive the organs.
Right.
And so their transplant rates, success rate is much, much higher.
So you're buying more time to allow the correct recipient to be ready.
Yes.
Right.
Yes. And also to the organs procured from the patients who have, disease, circulatory death. So in them, their organs are not as good as the organs from a brain dead donor. You see, so what they do is they actually revive those organs, the organs from the DCD patients.
Yeah.
They revive them and then only transplant.
Right. So
Yeah,
technology advancements is something I'm hearing, right? And I want to invite both of you to chime in on this because you mentioned a very important point, which is the fact that our healthcare system is sort of segmented.
Yes.
Or in my words, bubbled, right?
Bubbled,
How do we pop the bubble, right? How would you like government, public healthcare, private healthcare, university level, how should we integrate that collaboration in both your experience and opinions?
And that's very true, because for disease donation, the principle is organs should be shared.
Yep.
Organ sharing is something that will practice in other country, and it's not just about sharing within the country. Of course, it would involve also international and so on. But we look at our country first. First, we need to centralize the waiting list. Everything has to be under one national list. We have a kidney list. We have every organs that should be standardized. Then every donation in our policy also clearly stated, donation from the citizen of our country is a national resources that need to be allocated fairly and to be benefited by our patients. I mean our waiting list. So the thing is, we have quite struggles when it comes to the resources, facilities, human resources, surgeons, doctors, ICUs, and so on. So this is all our struggles. But we know that we have a few transplant centers. It's not necessarily from the Ministry of Health. It's also from university and private hospital. So we should be moving towards integration of these sectors to collaborate, to do together transplantation from the deceased donor using a national list. We should come up a mechanism to allow this and to support each other. If public hospital were burdened with so many transplant, we can give to other transplant center, which may be university or which may be private hospital, provided the national list should be enrolled and this is the same patient that should be benefited also. So this is where we need to go and to move forward. However, the mechanism is, I think, the understanding agreement between different sectors should be in the priority of our patients. That's all. Yeah.
Any thoughts from the hospital side? Any interchanges that should be happening there?
Well, I guess at this moment in time, probably doing what Dr. Hasdy suggested is the best course. But I think in the near future, we should be thinking about a transplant center. For example, we have IJN for the heart, and we have IKN for the cancer. So we should have a transplant center as well.
Right.
Actually, that's very true, because technically also all of our transplant center that we have now, they are not really a full dedicated center. They are still doing other procedures or other. So the need for Institute of Transplant that based at the hospital, we have a few now, even in Hospital Kuala Lumpur or Selayang, but that need to be transformed into a full institute that do transplant all the time. Yeah.
So a dedicated facility, a dedicated infrastructure that is really focused. I think the word is focus, right? To either empower the surgeons, empower the clinicians to supercharge this, right? So I want to give both of you some airtime, right? If let's say stakeholders and of course the public is listening to this, if you had one message to stakeholders today, what would that message be like?
My message would be, look, we did our very first transplant sometime in 1970, if I'm not mistaken, 75, 1975. And it's been more than 50 years and we are still struggling, And we know that there are so many patients, there are almost 50,000 patients on dialysis. Imagine how much it's going to cost the taxpayer, So all of that burden can be reduced by just doing a simple procedure like transplant. Okay, and the number of dialysis patients is going to increase every year with advancement in our medical, the way we manage patients and medicines, and more and more patients are being diagnosed every year, and the number is increasing. So there has to be a sustainable solution. Dialysis is supposed to be just a bridging, until the patient gets something more permanent. Yeah. So my message is that. Yeah.
Dr. Hasdy, yourself?
Yes, I think I agree with Dr. Prem. The stakeholders, we need to change our policy towards transplant. It has to become primary treatment. It has to become priority in our future policies, the healthcare transformation and so on. We have to change that, because if we still keep on thinking that transplant is only supplementary treatment and so on, we are not going to move forward or progress. That's number one. Number two, of course, for the donation. I mean, we need to ensure that the donation become a culture that were acceptable, and for the citizens of Malaysia to know, to be educated, and everyone should support organ donation. And this should become one of the national agenda that need to be carried every year without hesitancy, with the good strategies, national strategies, and commitment for all level of societies.
Yeah. So I think to all the stakeholders listening in today, there's clearly a lot more work to be done. We need to foster the priority and that focus, the collaboration between all the different sectors of healthcare. And I think for the public listening in today, registration is really easy these days, but more importantly, have that conversation with your next of kin, with your family members, and you too can be part of a really noble final act before you pass on. Right, Dr. Prem, Dr. Hasdy, thank you so much for the chat today.
Sure.
Thank you.
Thank you.